Good morning, everyone. I will be presenting on the topic to blind or not to blind. So, this is Mr. G from Aniyambadi, who is a driver by profession, presented with complaints of blurring of vision 5 days ago, with followed by headache for 5 days, giddiness for 5 days, and bumping into objects while walking for 5 days. There was no other history of any other cranial nerve deficits, any motor or sensory deficits, no history of vomiting, diplopia, seizure, fever, or any past history of trauma. Past history wise, he was diagnosed to have inferior wall MI in November 2018, for which he underwent PCI with DAS to RCA, and he is also known. He was diagnosed to have diabetes mellitus and hypertension 2 years back, but he was not on any regular medications. Personal history wise, he was a chronic smoker for the past 20 years, takes about 20 BDs per day with smoking intakes of 400. Moving on to the examination. At presentation, his pulse was 96 per minute, PP was 150 by 90 with respiratory rate of 18 and saturation of 96. JVP was not elevated. I would like to start with the central nervous system examination. His higher mental functions were normal. Examination of cranial nerves 2, 3, 4, and 6. Visual acuity was bilaterally projection of light at admission, which improved over 2 days. He was able to count fingers close to his bilaterally. Visual field on confrontation test, it was abnormal in all quadrants. Fundoscopy was normal. Pupillary reflex, both direct and indirect, were present. Bilateral pupils were 2 mm, equal and reactive to light. Accommodation reflex was present, and there was loss of Meniere's reflex. Other cranial examinations were normal. Gag was preserved. There was no deviation of tongue. Motor system tone was normal in all four limbs. Power was 5 by 5 in all four limbs. Deep tendon reflexes were 2 plus in all areas. Plantar bilaterally was withdrawal. Sensory system, fine touch was preserved. Vibration sense were diminished on over bilateral ankle. Cerebellar signs could not be assessed. Meningeal signs were negative. Skull and spinal were normal. Other system examination, cardiovascular, respiratory, and para-abdomen examination were within normal limit. So this was a gentleman who had present with, who was a known case of diabetes and hypertension with past history of myocardial infarction, who presented with the acute history of blurring of vision with progress to become loss of vision with headache and giddiness. On examination, has a normal normal fundus and pupillary reflex. So my clinical diagnosis was cortical blindness. So the differential considered for the cortical blindness was ischemic stroke, Anden syndrome, hypertensive encephalopathy, trauma, PMLE, and multiple sclerosis. So the investigation wise, his CBC profile was within normal limit. Renal, hepatic, as well as metabolic parameters were within normal limits, and BBVS was negative. On imaging, he had bilateral chronic occipital infarcts, and MRI done outside had hemorrhagic bilateral acute infarcts and hemorrhagic transformation in bilateral occipital lobe, splenium of left corpus callosum, and left ventral thalamus. So this is a case of bilateral occipital stroke who presented to us with a history of cortical blindness. I've seen so this is a case study, Anden syndrome due to cerebrovascular disease, wherein a 83-year-old lady had presented with history of bumping into object and confabulation. It was similar to my where my patient also had cortical blindness with some amount of confabulation. So discussion part, the patient was started on, because he had a bilateral hemorrhagic transformation. Patient was started on anti-edema measures, high dose statins. Platelets were withheld in view of in view of hemorrhagic transformation. So the learning point for me was the concept of cortical blindness and different etiologies of cortical blindness.
Alsy, thank you.